Welcome to the highlight in IBD by J&J Janssen นะครับ So our first speaker is Professor Aamir Khan นะครับ Professor Aamir Khan, he have accomplished a lot of things. So we try very hard to make it short นะครับ He is the past president of Pakistan Society of Gastroenterology and GI Endoscopy. Currently, he head the GI and Hepatology division at Lady Reading Hospital in Peshawar. He is actively involved in undergraduate and postgraduate teaching, and he is the examiner for MRCP and FCPS examination. He is currently international advisor to the Royal College of Physicians of London and also Royal College of Physicians of Edinburgh นะครับ Please welcome Professor Aamir Khan ครับ
Thank you very much. Bismillah ar-Rahman ar-Rahim. It's a pleasure. Nice to be back to Bangkok. These two gentle moderators at the chair are well known to me, and because of COVID, the meetings had stopped, so we hadn't come. So it's a pleasure to be back, and thank you for inviting me. That's another big pleasure. The topic we were going to discuss was inflammatory bowel disease status in Asia. For the students in the audience, obviously it's technically what we call a relapsing and a remitting disease. So it comes and goes. That's the unfortunate thing about it. And the IBD is generally, there are other variations of it, and the experts are sitting here. But Crohn's and ulcerative colitis is the main two IBD illnesses. Obviously, they are different in various ways. So the ulcerative colitis mainly affects the large gut, as you can see in this diagram, whereas Crohn's can be anything from rectum to mouth. It can affect. So that is the major difference between two. From personal experience, I'll show you that we seem to see two more, which one of them slightly more than the other. Obviously, it's I would say an emerging disease in this part of the world and rest of the Asia, but there's not much written about it. And you could see from the program, they were clever that, I got lesser time because there's not much I can speak about it because data is lacking. So it was once regarded as a disease of, what do you call it, westernized world. It was more common, but now as, because of the world becoming a smaller place and travel being easy, so it's become common in other parts of the world. And there has been increasing reports of incidents. And you could well imagine, you see Asia, India by itself is nearly now 1.5 billion. And I think by the time I finish this talk would be 1.5, the way, the population. And same applies to China. So in actual numbers, you see that's 2 billion of your, or 2.5 billion of your population. So the actual numbers of cases would be extremely high in these countries. And that is one of the difficulties we have. You could see that the prevalence and the pattern of the disease is slightly different. So those folks, as because of the globalization of the world and world becoming a smaller village, people have moved back and forth. Some of us, like myself, have spent nearly 30 years in Scotland. So there is a large Asian population in Europe and USA. And there are colleagues from that part of the world who explain. And you could see that their incidence, those who have been born but are of Asian origin, also have a increasing risk. Same applies here. So you see the phenotype is slightly different with slightly more male predominance in Asia. And there is some phenotypes that fistulizing CD is being more commonly identified currently as we speak of this illness. This is just a variation of whatever the prevalence we know of is, and you could see it varies from a low prevalence in Taiwan to a high in Korea, in some cases nearly 12. Japan has nearly 12.2 of ulcerative colitis. And the incidence varies because it's such a diverse region. Asia, Southeast Asia is such a diverse region with various cultures, various environmental factors and inheritances, that it can vary from various reasons. And incidence of Crohn's disease is high in some regions, as I pointed out. Where I come from, Pakistan, which is in Asia, we don't have much Crohn's disease. I hardly see any Crohn's, but we have significant, I wouldn't say significant, but compared to Crohn's disease, we have significant ulcerative colitis. That is something we've noticed. And where there is Crohn's disease, you would see that they have a slightly different phenotype, with perianal fistulizing disease being more common in that population. And that is the unfortunate thing, because it's difficult to treat, and the social connotations associated with it, especially in Asian culture, causes difficulty. And you'll see further on, I'll tell you that that leads to problems in detection. And so this was a study which is carried out, and which shows that there is an increasing trend, and your part of world is also being shown. Thailand has been documented that their incidence is increasing, and you have local experts sitting here who would probably highlight on that, what their view on that is. What we call the ASPR, you can see has increased. When you compare this with Western society, they're sort of ranging in 150-ish per 100,000, but still overall, and we have more prevalence in Asia. The IBD prevalence is slightly more in male population than compared to female population. In most region, not all region, but most region, what have been noticed is that the population prevalence is slightly more than younger males. And it is projected, this was a worrying study, that the prevalence will increase 4-fold to 2.5-fold. So now, as I mentioned, both these places have nearly billion plus population. So that will have a major impact on the healthcare system and the delivery if the population prevalence shows more by 2035, if we have more incidence of IBD there. Traditionally, it's been thought that we were protected, Asians, we were protected. And one of the reasons that was quoted was that people in Asia being culturally more sort of linked to family-oriented system, there was been breastfeeding. Westernization, what I call McDonald culture, wasn't there, but I think you'll find that now McDonald is more part of our culture than anywhere. Where I come from northern Pakistan, and it is a very culturally strong society. I live practically next to Khyber Pass, which is next to Afghanistan, and we hardly had McDonald's, but a place like my city has 2-3 McDonald's. And then, as you would have noticed, consumption of antioxidants like green tea is well known to cause antioxidant properties. And that was thought that those might be giving protective effects. But as the society is westernized, and breastfeeding has become lesser and lesser, and the diets have become more westernized, more refined, it has become, that might be the reason. Antibiotic use in most Asian countries I've visited, you can get antibiotics over the counter. Unlike USA, UK, where I practice, Arti's practiced, Canada, I think you can't just walk into a pharmacy, but in my part of the world, you could probably get it easier than you get Smarties packet. So you just walk in, and what that does is, I'm sure most of you are practicing physicians, IBS, most patients in my part of the world, when they have IBS symptoms, they take metronidazole, flagyl. They take it more often than their children take Smarties. But that might have some positive effect, that it might be reducing the incidence, but I'm not sure what is the data to support that. So obviously it's a difficult disease to treat. Difficult disease to pick up is even more difficult, because you need diagnostic modalities, you need awareness of it. As they say, what mind doesn't know, eye doesn't see. So I've practiced nearly 30 years in Europe, and when I moved back to Pakistan some years back, I started picking up these things where my colleagues would not be that keen on, but that is the reason. And you could see that it's not only clinical, you know, the clinical symptoms can fit in anything, but you require more modalities to pick it up. And, you know, most of these countries where we live in are economically challenged, and it becomes very difficult to justify or putting a patient through all these radiological, histological, endoscopic procedures. So you really have to think, you know, where we practice, people are really challenged economically, and one has to be very careful. To add to that, then we have other infections which can lead you astray. So it's it's like a minefield. So you have to make sure that you know, you exclude other things which can mimic IBD symptoms. And I'm sure most of your bosses, the senior ones, have had experience of this. I'll show you a slide just to tell you. And histolytica is common, and that, you know, is because of this poor sanitation and poor living hygiene, overcrowding, all that carry on that is associated. And this is just a slide which just gives you a quick rundown on how many things can mimic. And you see on this side of thing, Mycobacterium tuberculosis is something which I see often in my part of the world. Similarly, you know, with HIV and becoming more prevalent, these infections can mimic it. Parasitic I alluded to. Schistosoma is more common in Egypt, but we still see it. And obviously there are those non-infectious diseases which do occur. It's not to say, especially, you know, as I said, people use a lot of non-steroidals, bashes more in Turkey sort of population, but these are, so what I'm trying to say is that you have to be careful when you're looking at a patient that you don't miss these things which mimic them. Now, once the disease is picked or has to be picked, it causes problems because what happens is that patients are reluctant to come. As I mentioned, colonoscopy is something which is not freely available. We don't have programs of CRC screening as they have in the Western world. We would like to, but obviously that causes its own difficulty. One of the common things I see in my practice is that we have patients coming who have are told they have hemorrhoids, and they are treated for it and they're not getting better. They've had hemorrhoidectomies. Some have had awful things done by local quacks, like putting acids and things like that on the hemorrhoids, which causes problems, but ultimately turns out that they have something more sinister than this is similar, just like rather than simple hemorrhoids. So you have to be aware. And this all is because, as I pointed out, that, you know, the healthcare system is technically put on pressure. So it takes a while for the patient to you know, reach to a specialist, and therefore misdiagnosis is a big challenge. I think senior profs are sitting here. We've all seen tuberculosis being mislabeled, and that is what I was pointing out, that when I came back to Pakistan, a lot of cases which were diagnosed as intestinal tuberculosis, when we looked at it closely, because you see, there is a reason for it. The disease by itself is relapsing and remitting. So if they got a bit better by its own, they thought it was because of anti-tuberculous treatment, but that wasn't the cause. I wasn't going to talk much about management because we have experts after me who are going to talk about it, but I was just going to point out that, you see, obviously our management, the guidelines we have are from people who have unlimited resources. We have limited resources, so we have to be careful and you'll hear from the experts about it. You see, one of the problems treating inflammatory bowel disease is that it involves travel. So you see, the experts have to go to different parts of the world, and I had the honor of welcoming my Thai colleagues in 2000, before COVID, at my own place. And you can see how hard we worked for IBD. Thank you very much.
Thank you, Aamir. We leave the Q&A at the end of all speakers. So I'd like to introduce and invite the next speaker, Dr. Waqqas Afif. He's from McGill University in Montreal, Canada. He come all the way to give us a very informative talk, I'm sure. He's currently Associate Professor of Medicine and GI Division, Clinical Epidemiology at McGill University. He is at Montreal General Hospital. He's a GI Site Director and the IBD Research Director. He has a particular research interest in improvement of the treatment of IBD. So he will speak to us on the update management of Crohn's disease. So please welcome Dr. Afif.
Thank you very much for the introduction, and thank you for inviting me to come. My first time in Thailand, so I'm excited to be here. So I was asked to talk about the management of Crohn's disease in 2023. So here are my disclosures. And so we'll talk about the treatment targets in 2023 for Crohn's disease. We'll talk a little bit about the new medications that are available for Crohn's disease, and then we'll talk about optimal management of Crohn's disease in 2023, particularly with regards to treatment sequencing. So in terms of the treatment of Crohn's disease, so things have come a long way over the last 15 to 20 years. So in the past, we would treat to clinical symptoms, so clinical response and clinical remission, and things have changed, and now we're sort of targeting biochemical normalization, so normalization of CRP and fecal calprotectin, and obviously normal endoscopy as well. And so we feel that if you can sort of get to this normalization of endoscopy, that will improve quality of life, prevent disease complications over time. And so there are new guidelines. These are the STRIDE 2 guidelines looking at the treatment of Crohn's disease. And so you can see here the immediate sort of target in the first 2 or 3 months of treatment is a symptomatic response, so an improvement of your clinical symptoms. Over time, you want symptomatic and clinical remission along with normalization of fecal calprotectin and CRP. And then at that sort of 6 to 12 month mark, you want endoscopic healing with a normal endoscopy. And again, with that normal endoscopy comes hopefully a normalization of quality of life and an absence of disability over time. And so what's the point of trying to get to endoscopic remission? Well, the point is that if you can get to endoscopic remission, that also leads to a long-term clinical remission. So patients feel better over a longer period of time. And if you can get to that endoscopic remission, it also decreases your risk of having surgery related to your Crohn's disease as well. So this is why we're sort of moving from that clinical remission diagnosis to the endoscopic remission target. So are there ways to get there better and faster? So there's the treat to target algorithm that's kind of being put in place a little bit more frequently in our clinics. And so here you can see that there's a little bit more proactive monitoring of disease. So having a CRP and fecal calprotectin done early on in the disease within the first 3 months, and considering optimization of therapy at that 3 month mark, and then again at 6 months, and to have an endoscopy done sort of in that 6 to 12 month time period to see if there's been endoscopic remission. And if you're not able to get to endoscopic remission, to either, again, optimize the medications you're on or add a second medication or switch to a different medication. And so what's the data to suggest that this is the way to go? So we have the CALM data, which some of you are probably familiar with. This is using adalimumab and using a tight control algorithm as opposed to just clinical symptoms. So the main difference between the two arms here is that the tight control arm used fecal calprotectin and CRP at every 3 month intervals to optimize treatment. So if you're on adalimumab every second week and you had a high fecal calprotectin at month 3, you would increase your adalimumab to every week and optimize the treatment. And so if you can actually optimize to not just clinical symptoms, but also biochemical symptoms, you can see that there's an improvement in the overall rate of endoscopic remission, about a 15% delta with treatment optimization, which is quite significant. And so what are the options that we have in terms of the treatment of Crohn's disease? So I'm going to talk a little bit more about the biologic medications. So you can see here there's various different pathways. There's the cytokine pathway that you're quite familiar with, the anti-TNFs and the IL-23s and IL-12/23s. There's lymphocyte trafficking blocking with vedolizumab, and then newer to Crohn's disease is the JAK inhibitors, which we'll talk about briefly as well. And so with all of these different options that are available, the hope is that we can sort of improve the rates of clinical remission and endoscopic remission over time. So remember that whatever treatment we've used in terms of biologic treatment, the clinical and endoscopic remission hovers around 30 to 40% at that 1 year mark. So certainly not there in terms of getting to 80 to 90%, but there are different options that are available. And so these are our Canadian Association of Gastroenterology guidelines looking at the treatment of Crohn's disease. And so that sort of combination of clinical symptoms, objective markers of disease, and different factors that help us decide which patients need biologic therapy and which ones need it earlier rather than later. So clinical symptoms, as you can see here, younger age, smoking, laboratory factors, more severe endoscopic disease, fistulizing disease are high risk factors for a more complicated course, and these are the patients that need earlier treatment for their Crohn's disease. So what do we use for Crohn's disease treatment? So I'm just going to highlight them here, and then we'll talk a little bit more about the biologic medications. So, everything in IBD is about induction and then maintenance of treatment. And so for Crohn's disease and ulcerative colitis, we use corticosteroids, so mainly prednisone or budesonide, to induce remission. We use immunomodulators, so methotrexate and thiopurines like azathioprine for maintaining treatment. You can use methotrexate for induction and for maintenance. We can't use 5-ASA medications, and so most of the time in patients that fail corticosteroids or that are corticosteroid dependent, those are the patients that end up using a lot of biologic medications. And I'll talk about immunomodulators in a second. So you can see here there's a whole host of different biologic medications, the anti-TNFs, the alpha-4 beta-7, lymphocyte trafficking molecules like vedolizumab, IL-12/23, ustekinumab, and then 2 newer agents that were just approved over the last year, IL-23, risankizumab, and a JAK inhibitor called upadacitinib. So why are we using more and more biologic medications? One of the reasons is that there's not a lot of great data for azathioprine and 6-MP in the treatment of Crohn's disease. So I know that a lot of us have used this in the past, and there's obviously cost issues involved. Using azathioprine is a lot cheaper than the biologic medication, so a lot of patients end up being on these medications. But 2 studies almost 10 years ago now have shown that early use of azathioprine actually doesn't improve overall outcomes over time. So this is the RAPID study and the AZTEC study. So the AZTEC study taking patients that are bio-naive and randomizing them to either azathioprine or placebo, and you can see here that the sustained remission at 18 months was about the same whether you're on azathioprine or on placebo. So it didn't seem to have an overall effect in terms of getting patients into remission and keeping them into remission. And so now we're using a little bit more biologic medication. So fortunately, I am in a practice in a jurisdiction that has a lot of access to biologic medication, so we get to use quite a few of them. And I haven't used azathioprine or 6-MP as a monotherapy for Crohn's disease, at least in the last 3 to 5 years or so. So you're probably familiar with the IL-12/23 biologic agents, so ustekinumab, which blocks the P40 subunit, and then more newer molecules that block the P19 subunit, like risankizumab for Crohn's disease. Mirikizumab was recently approved for ulcerative colitis in the US and Canada, and other IL-23s are coming down the market for IBD, guselkumab as well. And so I'm going to just highlight 2 studies because these are the 2 newest molecules that we have, or the 2 newest biologics that we have for IBD. So This is the data for risankizumab. So they had two sort of induction populations in bio-naive and bio-experienced patients. And those patients that were in clinical response at week 12 were put into the maintenance study. If you didn't have a response at week 12, you were given another 12 weeks of treatment to see if you can get into response. And so in terms of the results, you can see here there's a significant benefit of risankizumab over placebo for getting to clinical remission and endoscopic response at week 12. And you can see here that percentages are around 45% or 35%. It's a little bit higher in the bio-naive population compared to the bio-experienced population, something that we've seen with almost all of the biologic medications. And then the week 52 data, again, sort of 40% clinical remission endoscopic response. And then finally, if you look at ulcer-free endoscopy at week 52, again, sort of that 30 to 40% range for having a normal endoscopy in responders on patients on risankizumab. So certainly an effective medication in Crohn's disease. One of the questions that comes up is, what if patients have already been exposed to an IL-12/23 like ustekinumab? Can you still use an IL-23? And the answer is yes. There is some preliminary data suggesting that if you fail ustekinumab at 12/23, that you can still have efficacy with an IL-23. And so one of the nice things about these medications is that they're very safe medications. So compared to placebo, almost no increased risk of any adverse events or adverse events of special interest. So really a safe medication in line with what we have with ustekinumab and vedolizumab as well. And so in clinical practice, as risankizumab becomes more and more available, so it works in bio-naive and bio-experienced patients. It works in patients that have failed ustekinumab in the past. In patients that don't respond to the first 12 weeks of induction, you can give another 12 weeks and get another 50% response rate. And as I said before, the safety profile is quite similar to ustekinumab and vedolizumab. So a nice sort of addition to our practice. And so what about the kinase inhibitors? So these are medications that we've started to use as well. And these are oral medications, and their name comes from, I was in Italy this summer and I sort of noticed the statue as well. So it's the Roman god January, and basically it's sort of two faces, one looking to the past and one looking to the future, and that kind of looks like the JAK receptor, basically. And so you can see here the JAK receptor, and there's different JAK receptors that are available. There's ones that target all of the JAK. So tofacitinib is a JAK1, JAK3 inhibitor, whereas upadacitinib is more of a JAK1 inhibitor. There's also newer molecules that are coming that also target this pathway, so the TYK2 inhibitors as well. So lots of new molecules are coming in this pathway as well. And so this is upadacitinib, which was recently approved for Crohn's disease. So remember, the other JAK inhibitor, tofacitinib, is only approved for ulcerative colitis. It didn't meet its primary endpoint in Crohn's disease. And so this upadacitinib is the first JAK inhibitor for Crohn's disease. And so these are the UXL and UXceed induction studies and the UEndure maintenance study. So a 45 milligram dose induction study, and then either 30 milligrams or 15 milligrams for maintenance. And you can see here that the 45 milligram dose improved clinical remission and endoscopic response at week 12 compared to placebo. So it was an effective medication in terms of getting patients into remission. What was interesting with this molecule is that you can see that as early as week 2, patients started feeling better. So there's higher rates of clinical response. And if you look at week 4, clinical remission, that you see about 30% of patients were in clinical remission at 4 weeks. So, and remember, in this population, these are patients that had failed multiple biologics in a subset of patients. So this is a difficult to treat population of moderate to severe Crohn's disease. And you can see here that to get clinical remission at 4 weeks is something that's quite impressive with this molecule. And so the long-term for a 52-week outcome, you can again see that it was effective in terms of clinical remission and endoscopic response with rates of about 40 to 50% or so. And interestingly, there wasn't a huge difference in terms of patients that were bio-naive and bio-experienced. So the deltas in those two subsets of patients was about the same, and so indicates that perhaps this is an effective medication, not just first line, but also second line or third line. And then finally, if you look at that endoscopic remission outcome, the 30 milligram dosing did do better than the 15 milligram. And so again, percentages sort of hovering around that 25 to 30% range that we've seen with all of our medications. So it's a very effective medication. In terms of safety, there are a little bit more safety concerns with this medication, so particularly herpes zoster. So it increases your risk of herpes zoster within that first year and onwards. And so in this study, only about 10% of patients actually had vaccination for herpes zoster with the Shingrix vaccine. But certainly this is something that's avoidable with giving the Shingrix vaccine. It does increase your liver enzymes, but none of the patients in the study had to withdraw from the study because of high liver enzymes. And then there is also perhaps a thromboembolic risk associated with this medication. And other studies with tofacitinib have shown that sort of older patients that have other cardiovascular risk factors might be at a higher risk of developing DVTs or PEs with this medication as well. So something to kind of keep in mind as you're sequencing all of these medications. So upadacitinib is effective in bio-naive and bio-experienced Crohn's disease patients. I would avoid using it in patients with significant cardiovascular comorbidities. Increases your risk of herpes zoster, which you can get vaccinated for, and the 30 milligram dose seems to do a little bit better than the 15 milligram dose, especially in those patients that were bio-experienced. And then it's also contraindicated in pregnancy because of some animal studies, so not something that you can use in younger women who want to become pregnant. So in the last 10 minutes or so, I'll just talk a little bit about sequencing. So, bear in mind that I'm coming from a jurisdiction where all of these medications are available. And I know that here and other places in Southeast Asia, as you heard about, that all of these medications aren't readily available. And so you always have to do with what you can. There are biosimilar medications that are available for anti-TNFs and also will be for vedolizumab and ustekinumab in the near future. So some of these medications will be available in the next few years or so. So how do you choose one biologic versus another? So there's not one great way of kind of looking. There's different drug factors, there's patient factors, there's factors at initiation, so whether the patient has fistulizing disease or other EIMs, physician factors, what is the doctor comfortable with? Is it an oral medication? Is it IV? Is it sub-Q? And what is the data for each of these medications? And so there's no great way of kind of figuring out which biologic is the best biologic. We have a couple of head-to-head studies that I'll show you in a few seconds. And then there's network meta-analyses that have been done for Crohn's disease. And you can see here that in patients that if you take all of the sort of pivotal studies for all of the biologic medications, and you sort of, again, it's not great to compare across trials, but if you try to balance everything out, if you look at patients that are either bio-naive or bio-exposed, and you sort of look through the list, you can see here those two medications that I spoke to you about just now, the risankizumab and the upadacitinib seem to do very well along with infliximab. So remember that in the infliximab studies, there was only bio-naive patients. There was no one that's bio-experienced with infliximab. So if you kind of sort out those bio-naive patients, the risankizumab actually came out on top in terms of efficacy. So you can see they're all effective medications, and they all have different sort of risk profiles, but certainly in terms of effectiveness, risankizumab, upadacitinib, and infliximab did well. What about safety? So safety, again, I think is what's driving this sort of push a little bit away towards anti-TNFs. And so you can see here that ustekinumab versus TNF antagonists, and again, this is another meta-analysis, sort of 50% less risk of infection with ustekinumab compared to the anti-TNFs. Vedolizumab versus anti-TNF antagonists, no major differences. And ustekinumab versus vedolizumab, decreased risk of serious infection. So you can see here that those newer molecules, particularly ustekinumab and vedolizumab, do a little bit better with compared to anti-TNFs that have slightly higher risk of infection and other side effects associated with them. So that's why we're moving a little bit more towards the newer molecules. And so are there any head-to-head studies that help us kind of figure out which molecule should go first? So this is the results of the CView study, which was published a couple of years ago. This was the first head-to-head trial in Crohn's disease. So this was comparing ustekinumab and adalimumab. And you can see here that they're both very effective in patients. And these are standard doses of the molecules every 2 weeks for adalimumab and every 8 weeks for ustekinumab. And you can see both were able to get patients into remission around 70% of the time after 1 year. So both effective molecules. Benefit of ustekinumab is that it's a bit less frequent dosing every 8 weeks instead of every 2 weeks. There was a second randomized control trial that was just presented at UEG a couple of weeks ago. I'll just kind of go through that because this, I think, is an important study. This is called the sequence study. This is looking at risankizumab versus ustekinumab in patients that had failed an anti-TNF. So they took patients that had failed an anti-TNF in the past, had active disease clinically and active disease endoscopically, and randomized to either get risankizumab or ustekinumab at standard dosing. So this is the primary endpoint. So there's two sort of primary endpoints. So one was clinical remission. This was a non-inferiority endpoint. And so you can see here that risankizumab was non-inferior to ustekinumab. You can see by the percentage points that it was probably more superior in terms of getting patients into clinical remission at week 24. And then the superiority endpoint of endoscopic remission at week 48 was about 15% higher with risankizumab compared to ustekinumab, so 30% versus 15%. And again, these are patients that were bio-experienced. There was a higher drop-off at the ustekinumab group as well, which probably explains why the endoscopic remission was higher in the RISA group. And then if you look at all the secondary endpoints, so endoscopic response, steroid-free endoscopic remission, and all of those endpoints combined, again, sort of a consistent advantage of risankizumab versus ustekinumab in patients with Crohn's disease. So how does this change your clinical practice? So I think in this study, which is a well-done study, that risankizumab was superior to ustekinumab in a refractory group of patients. So these are moderate to severe patients that were anti-TNF exposed. Risankizumab did better. We need a little bit more data in terms of all the subgroup analyses. And I think, the question really is, does this apply to all patients? Because remember, these are patients that were anti-TNF exposed. So in a bio-naive patient, is risankizumab better than ustekinumab? And that's a bit unclear. From the CView data, if you look at the endoscopic remission rates for ustekinumab, they were about 30% after 1 year. So a sort of a similar endoscopic remission rate that you see with risankizumab. So in the bio-naive population, it's still not clear whether RISA would do better than ustekinumab. So what's in the sort of horizon in terms of what else can we do to increase those rates of endoscopic remission? So as I mentioned, sort of 30 to 40% across all of the biologics. And so is there anything that we can do to sort of increase that amount? So there's dual biologics. So this is results from the Explorer study, which just a one-arm study taking patients with more moderate to severe disease and starting them on vedolizumab, adalimumab, and methotrexate. So 3 medications all at the same time. And you can see here that when you look at sort of endoscopic remission, sort of 35% at week 26. And if you sort of take an observed cases of patients that were actually on the medication, a little bit higher at 42% after week 26. If you compare that to sort of vedolizumab and the Versify data around the same time period, and you can see that the endoscopic remission rates are about 20%. So about doubling of the endoscopic remission rates when you add adalimumab and vedolizumab together. So certainly something to kind of consider in terms of trying to increase our rates of endoscopic remission. So similar to the hepatitis literature, once you start adding a couple of medications together, or the HIV sort of paradigm, that when you start adding a few medications together, that things will probably be a little bit better and get patients at a higher chance of getting them into remission. There are some other sort of smaller studies taking a look at dual biologics, either with a biologic and a small molecule, or 2 biologics. And again, small studies that have shown that there's benefit in a refractory group of patients to try combination therapy. And then there's randomized control trials that are ongoing. So the DUET UC and CD studies that sort of combine an anti-TNF and an IL-23, so guselkumab and golimumab, are ongoing, and so will give us a better idea of whether this combination therapy, and these are studies where they sort of combine both molecules into one syringe, have actually an improved benefit. In UC, there was a little bit of benefit with the combination therapy, so it remains to be seen with Crohn's disease whether adding 2 molecules together will improve outcomes. So in the last 2 minutes, just to conclude, there is a little bit of a a push towards moving away from anti-TNFs if you have the resources to do it. They're great medications, they work really well, but there are some safety concerns. So if you have obviously fistulizing disease or you have axial spondyloarthropathy, then you still would obviously consider an anti-TNF first. But for other patients with moderate to severe disease without any of these extraintestinal manifestations, certainly there's a little bit more data to suggest from a safety profile that vedolizumab, ustekinumab, or risankizumab would be effective in bio-naive patients and safer. I think if you're in a patient that has already been exposed to anti-TNFs with the recent sequence data, I think risankizumab would be a good second choice. And then upadacitinib, which is a very effective medication. It's oral, and it works effectively in bio-naive and bio-experienced patients. Could be sort of reserved as a more of a second-line or third-line agent, particularly because of the safety profile in terms of an increased infectious complications. There's a move towards a little bit more oral therapy, so JAK inhibitors, S1P modulators that we'll talk a bit more in ulcerative colitis, but also being studied in Crohn's disease. So etrasimod is one S1P modulator that's being studied. So, it's obviously more convenient to patients to have oral medications, but there are a few more safety concerns with either of these medications. And there's ongoing studies taking a look at oral integrins and oral anti-TNFs, which I think will change the landscape as well. And then finally, sort of that move towards using dual biologics or molecules that target multiple mechanisms of action, again, sort of borrowing from the HIV literature, that the more targets that you sort of can engage, the better chances you are getting into remission. And so we've started to use dual biologics in very refractory patients, and certainly there's going to be ongoing studies with Crohn's disease and ulcerative colitis, combining different agents to see if they're effective in terms of getting patients into remission. And I'll end with that. Thank you very much.
So thank you, Dr. Afif. So we move on to the next speaker.
Next topic will be the practical management of ulcerative colitis by Dr. Arti Wongcha-um. Dr. Arti is a certified MRCP in medicine from UK. He completed his GI fellowship training at McGill University in Montreal, Canada. He has special interest in the IBD, and currently he is a GI staff at the Julapur International College of Medicine, Thammasat University. Please welcome our rising star in IBD.
So thank you very much, Professor Pises and Professor Mahachai, for the kind introduction. And thank you, Professor Khan and Dr. Afif, for the very interesting talk. And I would like to add to the session by talking about the practical management of ulcerative colitis in Thailand. So Thailand has the lowest incidence of ulcerative colitis in the Asian Pacific region, quoted at 0.2 per 100,000 per year, which is much lower compared to the US incidence of 2 to 14 cases per 100,000. However, IBD cases are increasing in the Asian Pacific countries, possibly due to environmental factors and, as Professor Khan mentioned, and also improved healthcare leading to more diagnosis. Over the past 20 years, new treatments in UC have led to reduction in hospitalization and colectomy rate, and biologics have revolutionized the management of IBD. However, options are still limited in Thailand due to lack of coverage through the National Universal Healthcare Program. And given that the incidence is increasing in Thailand, there is a need to understand the up-to-date management of UC as more treatment options will become available. Currently, there are no Thai guidelines for the management of UC, so we rely mainly on international guidelines, such as the North American and the European guidelines. So the goals of management in UC is to establish the diagnosis, determine the extent of disease, as the choice of initial treatment will depend on the severity and the extent of the disease. And management can be divided into the induction phase and the maintenance phase. And ultimately, the long-term goals are to prevent complications such as cancer, need for surgery, infections, hospitalization, as well as monitor drug side effects, as the medications will have to be taken long term. So one way to determine the severity of UC is the long-established way using the True Love and Wits criteria, which takes into account clinical features such as bowel movements, blood in the stool, fever, and dividing them into mild, moderate, and severe. In more recent years, a more robust scoring system called the Mayo scoring system for assessment of UC activity has been developed. And you can argue that it's more objective as it takes into account endoscopic findings as well as clinical features. So after you determine the severity of UC to help guide therapy, it's also important to assess the risk for the need for colectomy in the near future. Low risk factors, this will also help guide management. Low risk factors for needing a colectomy include limited anatomical extent and also mild endoscopic disease, whereas high risk factors include extensive disease, needing steroids, deep ulcers, history of hospitalization, age less than 40, C. diff infection, high CRP, CMV infection, and low albumin. So in mild to moderate UC, the cornerstone of management is by using 5 ASAs. 5 ASAs comes in various preparations and various routes of administration. So if the disease is mild and it's limited to the rectum, the 5 ASA suppository may be adequate in achieving remission. Whereas if the disease extends beyond the sigmoid to the left side, then the suppository doesn't reach. So you have to use 5 ASA enema. And that's more effective if you combine it with oral 5 ASA. And if the disease is extensive, then use oral 5 ASA, and you can combine it with the rectal option. If the disease doesn't respond to 5 ASA, then you can consider stepping up to oral budesonide at 9 milligrams per day, or if it progresses to more severe disease, but the patient doesn't quite require hospital admission, then you can use oral prednisone. If the disease is ongoing despite using rectal 5 ASA, then rectal corticosteroid can be added. For maintenance, 5 ASA suppository may be adequate for proctitis, and oral 5 ASA for more extensive disease. So if the disease progresses to more moderate to severe UC, then conventionally the next step along the pyramid would be to use thiopurine such as azathioprine and 6-mercaptopurine. And these should be considered in cases that are not responding to maximal doses of 5 ASAs, and those who have required multiple courses of steroids. But thiopurines have slower onset of actions and are usually started with steroids and continue after the steroids are tapered down. But more recently, the AGA guideline in 2020 recommends that in adult outpatients with moderate to severe UC, they suggest early use of biologic agents with or without thiopurines rather than the gradual step-up approach after failure of 5 ASAs. So the new shift in management is that, as the North American guideline suggests, is that if you deem that the patient may have high risk factors for progression of disease or high risk factors for needing a colectomy in the near future, then you can bypass using thiopurines and go on to use the biologics straight away, even in moderate cases. And in patients who require step-up therapy and achieve remission with biologics and or immunomodulators or small molecules such as tofacitinib, the AGA recommends stopping 5 ASAs as they have not been shown to be effective in maintaining remission in severe disease. So this algorithm is from the AJA guideline, just a summary of what we talked about. So in the management of mild to moderate UC, so you determine the severity of a disease, then and the extent, and start with 5 ASAs. And if the disease progresses, you can either go step up to thiopurines, or if you deem that the patient has high risk factors, you can bypass thiopurines and go straight to biologics. So in the North American guideline, these are some of the options they suggested for the options for in high risk UC on the outpatient basis. So apart from thiopurines, the biologics that have been suggested that could be used include vedolizumab, ustekinumab, adalimumab, infliximab, and the new molecule, small molecule, the tofacitinib. So this is a landmark trial in UC, the UC success trial, showing that by combining thiopurines with anti-TNF biologic, azathioprine with infliximab specifically in this trial, it actually lowered the rates of anti-drug antibodies and increases, gives a higher concentration of biologic, and these factors lead to a higher efficacy in treatment. So the AGA guidelines suggest combining anti-TNF agents, vedolizumab or ustekinumab with thiopurines, rather than either therapy alone in moderate to severe UC in the outpatient settings. But bear in mind that with thiopurines, there is a risk of the fatal T-cell lymphoma, and the risk goes up even more when you combine it with anti-TNF, although anti-TNF monotherapy alone hasn't been shown to be linked to the T-cell lymphoma. So in acute severe ulcerative colitis, the patient will need to be admitted to hospital with close monitoring, rule out UC complications by getting abdominal imaging, rule out coexisting infections such as C. diff, TB, perform FLEXIC to document severity, and rule out CMV, avoid performing a full colonoscopy in cases of severe colitis due to risk of perforation. Always anticipate that if the patient fails IV steroids, they will need a biologic, so do a full biologic workup by getting a PPD skin test for TB, HIV, hepatitis B, and C serologies. Don't forget VTA prophylaxis and start IV steroids. The Oxford criteria is used to assess the response to steroids after 3 days. So if you still have high CRP greater than 45, or stool frequency of 3 to 8 or greater than 8 after 3 days, then that suggests failure to respond to steroids, and medical rescue therapy or a colectomy should be considered. So when you have failure of response to steroids, then always get early surgical consultation in case the patient will end up getting a colectomy. Consider doing a repeat FLEXIC to evaluate endoscopic response to treatment. And your options for medical rescue therapies include infliximab or cyclosporin. And if all else fails, then surgery. The ACG clinical guideline for ulcerative colitis in 2019 says that if patients respond to infliximab rescue therapy, then they should be continue on maintenance dosing at week 2, 6, and then every 8 weeks, and consider adding thiopurines. Patients who respond to IV cyclosporin should be switched to oral cyclosporin, then start thiopurines during steroid taper to maintain remission. Vedolizumab is also another option to maintain remission after cyclosporin induction, as cyclosporin cannot be used for long-term maintenance. Patients who fail to respond to cyclosporin or infliximab should undergo colectomy. So what are the current uses of biologics in Thailand? So currently infliximab is the only biologic available through the universal healthcare coverage for Crohn's disease, but not in UC. So no biologics at the moment are covered through the universal healthcare coverage in Thailand for UC. But infliximab, adalimumab, and vedolizumab are available through the civil servant benefit, and additional biologics, including ustekinumab, are available through the private insurance. So if a patient is not eligible for biologic, then if they failed IV steroids, then cyclosporine could be considered as an option for medical rescue therapy. But due to wide unavailability of biologics in Thailand, currently, thiopurines are frequently used as long-term maintenance options, even in severe cases of UC. So what do I suggest as practical options in Thailand if infliximab fails? So other options, as I said, that are available through the civil servant benefit include adalimumab and vedolizumab. So if you look at a head-to-head trial study, the Varsity study, which compared adalimumab and vedolizumab, it showed that vedolizumab is more effective at achieving clinical remission after 52 weeks. Hence, the AGA recommends using infliximab or vedolizumab over adalimumab in patients with moderate to severe UC who are naive to biologics. So I just want to briefly mention about the small molecule JAK inhibitors, which has been recently approved, FDA approved in North America for treatment in UC. Dr. Afif has mentioned briefly already about how effective they are, and in the Octave study, they have been shown to be effective in achieving clinical remission and mucosal healing, and can be used as induction and maintenance agent better with a 10 milligrams BID dosing than 5 milligrams BID. So 10 milligrams BID would be the induction dose, and 5 milligrams BID is usually the maintenance dose. So as you can see that there are many options available for the use of biologics. So what factors determine what a GI physician may choose in treating their patients? So one factor is availability of the treatments, if there's insurance coverage, also the efficacy based on guidelines and clinical trials, and also the experience each individual GI physician may have with using one agent over the other. Also take into account the side effects of each agent. The phenotype of IBD or UC is also important, because if a patient has extraintestinal manifestations such as psoriasis or arthritis, then anti-TNFs may be a better option. Whereas if you have an elderly patient with more comorbidities, or the disease is more specific to the gut, then vedolizumab may be a better option, because it's more gut specific with less side effects. So in the near future, there will be more options of biologics becoming available in Thailand. Partly due to the development of biosimilars, which have different quaternary structures to the biooriginals, and they can be sold at a cheaper rate. So a recent study we did in Canada at McGill showed that by switching patients from biooriginals to biosimilars, there were no significant changes found in clinical efficacy biomarkers, therapeutic drug monitoring, or anti-drug antibody levels in the first 6 months after the switch. So this pyramid just summarizes the conventional bottom-up approach in treatment of UC. So start with 5 ASAs. If that fails, go on to thiopurines and then biologics, and if all else fails, then surgery. But the new top-down approach in management of UC that has been suggested in the North American guidelines in recent years is if you deem that a patient may have high risk factors for progression of disease or high risk for needing a colectomy in the future, then you may bypass the thiopurines and go on straight on to biologics, even in moderate cases of UC in the outpatient settings. So in summary, Mr. Chairman, ladies and gentlemen, so the incidence of IBD, including UC, is going up in Thailand. So better understanding of the disease and its management is needed. Biologics have revolutionized the management of IBD in the last decade, and there are new emerging therapies, but barriers exist in Thailand. But as more biologics become available and GI physicians encounter more cases, they will have to keep up to date with the new treatment options. So there is a need to develop an own guideline in Thailand in the management of UC based on the currently available treatment options in Thailand. Thank you very much.
So is there any question from the audience? While we are waiting, I want to ask Professor Aamir. Because Professor Aamir is, I only feel doctor that have extensive experience in treating patients in both Western country and in Asia.
Yes, yes.
I don't know when you make diagnosis for IBD patient in Western country and in Asia, do you investigate them the same or is there any difference?
Obviously, you see, as Atif pointed, biologics is something, which is difficult. We have subset of patients. It's not that all are poor. There are rich people in Pakistan and very rich people. So we have access to them. By and large, you see, the problem we face is that hepatitis is very rampant, Hep B especially. So I'm not sure what your experience of Asian population in Canada is, and tuberculosis. So they have to be looked for that. Some, like going through very, like we were discussing, say, fistulizing disease, or, you need to dilate the fistulas and things like that. That sometimes can be challenging. But most of the time, if they're going in biologics, then we would investigate them a bit further than we would ordinarily. Our bread and butter still is mesalazine. I'm afraid that's what it is. And I had some slides, but because these two gentlemen were talking, so it's a cheap drug. Seems to do the trick. I am not sure, looking at what my experience from Western thing is, the disease there is quite widespread with a lot of extraintestinal manifestations. We don't see a lot of extraintestinal manifestation. Fistula, perianal disease, yes, but other ones, we don't see. So it is, as understandably, the investigations are tailor-made.
Thank you, sir.
For Dr. Afif, for the moderate to severe IBD, whether UC or Crohn's disease, you use a step-up or step-down approach, and what's your first-line agent?
So again, I think it just depends on what you have access to, right? So in our jurisdiction, we have access to all of the medications. So for first line ulcerative colitis, I think after you fail 5-ASA, we would go to maybe vedolizumab or ustekinumab would be the first line agents, just because they work well and they seem to be a little bit safer than the anti-TNFs. And the anti-TNFs, it's already pointed out, you need combination therapy, so you don't have to worry about the azathioprine. If you're just giving vedolizumab and ustekinumab, you can give those as monotherapy. And then for Crohn's disease, again, it sort of depends if you have, there's no good 5-ASA option for Crohn's disease. So I think if you fail your steroids and you have enough moderate to severe disease, then you'd probably want to use, again, one of the newer agents, so either risankizumab or ustekinumab or vedolizumab as your first line agent. Again, the TNFs are very effective. And especially if you have extraintestinal manifestations, the TNFs are probably the way to go. But otherwise, just from a safety perspective, if you have access to the other medications, they are a little bit safer to use for patients.
Much biosimilar in Canada?
So we've started to, yeah. So we have biosimilars for infliximab and adalimumab. So our provincial authorities have actually forced everyone to switch from the brand names to the biosimilar medications, and we've had a very good experience. We haven't had any complications associated with that. So those are readily available. There's 2 for infliximab, and we have about 5 different biosimilars for adalimumab. So the costs have gone down a little, 30 to 40% or so. For ustekinumab, the biosimilar is going to come in the next year or so. And then tofacitinib, which also turned biosimilar to, or became generic basically. So that has a significant cost decrease association with it as well. So I'm not sure if you have access to tofacitinib here, but it is generic in North America.
Thank you. Any other question from the floor?
So, Arti, I was going to ask you about Thailand. So you said guidelines, but what do you mean guidelines are not available? It means not modified to your, your society is very robust. So how come? And if not, you are the right person to do them then.
Because in Thailand we don't have a specific guideline that for management of UC, and so we actually look at rely on the North American guidelines a lot, and or maybe European international guidelines that are available. But as you can see, the options in Thailand may be different to the options that are available in America or Canada or UK. So I think as more options will become available in the future, we should have one that is specific to what is available in Thailand. For example, I don't think the tofa is the small molecule is approved for use in IBD in Thailand yet.
Could I ask you, do you see much of Hep B and tuberculosis, gut tuberculosis and hepatitis B in patients?
Yes, there are a lot of hepatitis B and C in Thailand, so it's important to rule that out before starting any management. And also TB colitis is common as well, and may be more common than IBD in Thailand because it's very rare. So before starting any aggressive immunosuppressant agents, it's important to rule out those things first.
In the private setting, we screen everything, hepatitis B, C, stool tests, capoprotectin, and also cortifolon for TB, all of them. But sometimes difficult in the government hospital because it's costly.
It is costly. I think that's sometimes, in practical reasons, we just explain to the patients and, give them a choice and just do a symptomatic treatment and see how they go. One of the big difficulties we have, especially at Waqqas, is that
TB.
you start treatment, a patient can go to get it from Dubai or something, but because there is no regular supply like you have, it really is challenging when they can't get hold of it. So they've had a course, and in middle of the course, they can't access it either because the flights are issued or the smuggling isn't going as well as it should or things like that. So these are all practical issues we deal with.
So what association with IBD and lymphoma have you experienced with? Maybe Afif, doctor?
So in terms of the lymphoma, it's mainly with azathioprine. So there's the non-Hodgkin's lymphoma. So in the baseline population is about 2 per 10,000, and then patients on azathioprine is about 8 per 10,000. So it does increase your risk by 4 times, but the absolute risk is relatively low. And then there's the risk of severe hepatosplenic T-cell lymphoma, which is sort of in younger male populations that are on azathioprine or on combination therapy. But again, that's quite rare. But again, another reason that I don't like to use a lot of azathioprine, if I don't have to, just because we don't have to explain that risk to patients when we're starting biologic medications, because the risk for lymphoma with the newer biologics, there's no risk. And then for infliximab, there's sort of varying data in terms of if there's actually an increased risk or whether that risk is associated with previous azathioprine. So there's not great data for lymphoma for the anti-TNF. So I think most of the risk for lymphoma is associated with the thiopurines, which again, if there is a possibility to avoid those, then great. If not, then we have to explain the risk to the patient and then follow them closely.
Mr. Afif, do you test EBV before starting the treatment?
It's a good question. So there is this association. If you look at the patients that develop non-Hodgkin's lymphoma and you sort of biopsy them, they're mainly EBV positive patients. So so you can. So we've had sort of lots of thoughts about whether we actually should be testing for EBV beforehand, but we don't do it on a routine basis. Again, it's not 100% clear that even if you had EBV, whether starting on azathioprine would sort of increase your risk of lymphoma. It might be just sort of an association that you have EBV there, but it's not clear that it's directly related to having EBV, in your exposure to previous EBV that you've cleared. So I think in general, we don't. There's not a lot of evidence to suggest that you have to. I think if you're going to, when I speak to Dr. Colin Bell, who's sort of one of the experts in this area, he doesn't really routinely measure it just because there's not a clear change. And again, if you don't have a lot of options, even if you're EBV positive and you don't have any other options, you're still probably going to start the azathioprine anyway. So in the grand scheme of things, it's probably not going to make a huge difference in terms of whether you're EBV positive or not.
I think we have learned a lot from all three speakers. So I think it's time to close this session. Thank you to the speakers for the very informative lectures. So thank you.